So we're going in on a special case. The guy's had surgery 2 times before. And I'm not gonna lie to you, I have questions about whether or not we can actually help this guy. So here we go. When was the first time you noticed you had gyno?
I was about 12, 13 years old.
So puberty kind of stuff, okay. And then when was the first time you had your the first surgery?
I was 19 years old.
Okay, and what'd they do during that surgery?
Liposuction.
Just liposuction?
Yeah.
Now, were you heavier at that point in your life?
As an early teenager, up until I was about like 14 I was, and then I lost weight, and then I was super skinny.
Forever, okay. Yeah. And so they did the liposuction, and you still had gland, right?
Yeah.
Okay, and then you come back, how long ago was the second one?
I was 20 years old.
So you did those like back to back?
Pretty short time frame, yeah.
Okay, and then he removed gland?
Yep.
Okay, and then you mentioned something to me earlier about the pec muscle. You don't remember your muscle looking like that beforehand, right?
Yeah, I don't remember having this asymmetry between the right and left before.
Yeah. And has it looked just like this since then?
Yeah.
Pretty much. Okay. All right. So I'm going to go over his previous incision. So he's got an incision here. He does pretty well. He's got this little incision here, this one, and then that one right there. Okay. So this is my question with this patient. And usually I don't have questions. I'll tell you that. So, flex your muscle for me. Okay. This right here, which I would normally say is, when I looked at his photos, and I studied your pictures before you came in, I thought, oh yeah, we'll even this out. This should be fine. This is going to be straightforward. We got this guy, right? He flexes this muscle. Do it again for me. I'm sorry. This, to me, feels like his muscle. Now, Dr. Caridi's going to come in here, right? And he's the man. He's going to tell us what he thinks. But raise up your arm and flex again. See, there's just nothing to take here. You see the striations of his muscle here. You also see he has high ribs right here. So anything behind that, okay, put your arm down. Anything behind this is being pushed out further, right? My concern with you is I don't feel any gland, right? I don't feel anything. This is soft, this is smooth. And I'm still assessing you as I go along here. So I have the right to change my mind at any moment. But I don't feel any gland. Maybe just a small little, maybe scar, a little something right there. But nothing significant. I'm going to come over to this side. We'll switch places. All right. Flex again. Okay, you see this. You would think, okay, that's something we can take. But again, this feels like his muscle. Raise your arm up again for me. So he's got high points in his ribs. Right here, and I know you can't see that as much as you can see it here, but this is a high point. So anything behind here is going to be pushed out. But right here, you can tell there's nothing behind the nipple, the areola, right? So there's no gland to take. Okay, relax the arm down. Another thing I'm looking for always is, well, maybe it's not gland, but is it fat that we can take? This guy's shredded. He works out. We're not doing anything with liposculpting. So the back and forth between Dr. Caridi and I this morning has been, I don't know what we're going to do for him. And so he wanted us to capture this on video because this is a reality of limitations. And maybe he comes in here and he says something totally different and we do this amazing surgery and it's going to be like perfect for you. And I kind of hope that because he came a long way and I want to help him. That's what he's hoping for. But we're going to get Dr. Caridi in here and show you the rest of the story. Real quick, I want to bring your attention to something. We really appreciate you guys watching, but 96% of you, 96% are watching these videos regularly and you're not hitting the subscribe button. So please go do that now. When you do that, it helps us grow our community. It helps us get the word out, educate others, and in turn, just help others, okay? So hit the subscribe button and continue watching.
Hello. Nice to meet you. Good to see you. So we've been talking about you. They've been talking about you.
That seems interesting.
And I know. We're going to make you interesting. So they leave it up to the Maharaji here to sort of figure out what's going on. So 2 previous surgeries. Fit. Right?
Very fit.
Good muscles. Thin body. This doesn't have a lot of fat to deal with. Good pecs. And then I'm looking at him like, okay, so what are we dealing with? So this, not much of anything. Not much of anything. So I can't feel a darn thing in here. Okay. Now put your hands on your hips. Squeeze hard. That's his pec. This is his pec. This is all his pec muscle. So you can imagine if his nipple were here. Okay, now relax. All right, relax. All right, so tell me what your issue is.
The issue is with, I get like pain and puffiness like feels like on the outer area, as if like there was something left out here. And it seems like this specifically on the outer portion has like, it gets inflamed and it's grown a little bit over time. Like it's gotten larger over the past, few years especially.
Have you ever torn that muscle?
No.
Okay.
Flexion muscle. Okay. So he's right. I mean, he's got some tissue here that he doesn't have over here. This is all his normal anatomy, by the way.
If you raise his arm up, you can see how far his ribs stick out.
Mm-hmm.
Raise your arm up.
Beautiful ribs. And so the only thing I can see is that, let's say this side compared to this side, he's fuller right here where he points out. Right here. So he definitely has this tissue right in this region over here. Now, the fact that he feels it and he gives tenderness,
Yeah.
not a lot, but enough. And if we remove this, will it make you happy?
I think so. I just want that pain to go away. And
So if there's something
yeah.
that's in here that's causing pain,
Yeah.
if there's tissue that's causing pain, I can promise him I can absolutely remove that, so that's not a problem. So, and it'll make him look more even, because this I definitely saw from the beginning. There's just some fullness on the outside. At first I thought it was his pec muscles. Sometimes there's always a difference between the left and the right. But it is definitely some tissue right over here. So voila.
There you have it.
Right in here. And so we remove that, the pain will be gone, and then his muscles will look more perfect side to side. Agreed?
Yeah.
Okay, so then the next thing, we're going to have to torture him a little bit. Do you have body dysmorphia?
No, I don't think so.
So,
I mean, working out for many years, always want to improve, but
you think he's got? Ah, boy. There's another person in the room who's like being,
Who knows him better?
Oh boy. So the interesting thing about why I asked the question is that body dysmorphia is sort of like a spectrum, and we all have sort of some body dysmorphia to some degree. Some of us have the opposite, where I just think I'm unbelievable and I'm not that good. So body dysmorphia to some degree is that we just kind of perseverate and we think overly about things that are relatively minor but cause a lot of angst in our lives. So to be this fit, sometimes, we're more critical. Not everybody, and it may not be him. But I could tell you, in his particular case, the fact that he's picked this out specifically, and something that he recognizes, and something that I recognize, if I contour and remove this, as insignificant or as small as it looks, it's a BFD, it's a big deal, and I dare say it'll bring him home, in the sense that, why would he be here unless it bothered him? You know what I mean? It bothers you enough to come down, and why would you subject yourself to surgery and scrutiny and all this kind of stuff? So what I like to tell everybody is that, he's fit, he's good. This isn't major, but it's enough. And if we can fix it and bring him back, it's going to make a big difference. And my history of doing literally, thousands of people just like him, where it's easy for us to say, oh, it's nothing, don't worry, go away. And it doesn't go away, right? And And if I treat it and it goes away and he doesn't have that pain and he feels better about himself, that's a good thing, not a bad thing. And if he goes to a good place where his health is assured and it's going to be reliable and predictable, I think that's just a great thing. So, cool. Right? What questions you got for me?
Nothing. I'm just looking forward to getting it done.
Get it done.
So nothing, we're not treating the other side.
Not need anything on the other side.
And you realize nothing is going to change about the midline.
Yeah, I understand that.
Those
Okay.
are facts.
Although with the right side, I still do feel like the sensitivity, and I know that the previous surgeon said that he wasn't going to remove the entire gland. He was going to leave a portion of it in so it didn't concave at all.
Yeah.
So I have good reason to think that there's still at least
Okay,
some
I'll
gland.
open it up. How about
Okay.
that? I'll open it
Yeah.
up with a small little. Well, you already have one, hopefully. I'll open it up. I'll take a look, and if there's anything in there, I'll do that because after you've had that conversation, then you got it. Because if I don't, then it's like you didn't do what you could have done easily. So easy enough.
Yeah.
But on the right side, you just don't have a heck of a lot, obviously. But I think this is going to be make you whole. There's no question about it. So that's what we're going to do, and I feel good about it. How about that?
Sounds good.
Do you agree with that? You think this is going to make him whole?
I think it's going to.
We're going to
Okay.
make them whole.
Good.
All right, we're in.
We're in, huh? All right. So we were talking with Micah back there, our videographer, about the nature of this case and all that stuff. Kind of raises some interesting questions. This pretty much will turn out to be a. Did you inject the local over there?
Dr. Wilson just injected.
Inject a little bit around there as well. And so, what's interesting about him?
Local or injection? No,
Local.
tumescent. Okay. Can I have some local?
So, two things about him is A, we're going to definitely treat an area that bothers him a lot. And then he told me at the last minute about this issue here. And I don't really feel anything underneath there, but I'm definitely going to look in there because if I don't, it's going to spook him. And I've always learned that you got to really listen carefully to your patients because they usually tell you that something's going on, and there usually is. I mean, not always, but usually. And although,
Yeah.
you guys watching this video are like, well, this is nothing, right? Well, enough to bring him to have another procedure, which is interesting. And also something by history I've learned that if I just ignore them, then they're just not going to be happy. And when I do these things, they're generally happy. So there is this positive clinical experience from intervening and trying to make something seem pretty minor better. And that's all we're trying to do. I can definitely feel scar tissue through this area. I mean, it's hard for me to even push this vaser. And as you saw, we had something in there. One of the things that Micah also and I were talking about BDD, right, Micah? Heather, read the BDD stuff. There's a list. It's kind of interesting.
Is it on his desk?
I've got it.
Okay.
And
when you first injected some stuff at the top, and then it kind of swelled up, what was it swelling up?
just the skin, really. That was just tumescent fluid or the saline solution that has some epinephrine in it and some lidocaine. So the numbing effect, but also hemostatic effect, makes the surgery less bloody.
Can I have some more of it? Sorry.
And like I said, I'm scraping in here, so I can definitely feel the scar tissue. So, you know, whatever it is,
So the symptoms of
Body dysmorphia disorder include constantly checking yourself in the mirror, avoiding mirrors, trying to hide your body part under a hat, scarf, or makeup, constantly exercising or grooming, constantly comparing yourself to others, always asking other people whether you look okay, not believing other people when they say you look fine, avoiding social activities, not going out of the house, especially in the daytime, seeing many healthcare providers about your appearance, having unnecessary plastic surgeries, picking at your skin with fingers or tweezers, and feeling anxious, depressed, and ashamed, or thinking of suicide, so suicidal ideation. Those are your symptoms.
Well, that's not quite a list there. And what I tell a lot of people is that we all have some elements of BDD, but it's when it becomes a true problem. It raises to that level. And it's always interesting that every time I ask somebody if they have BDD in a room, when there's another person in there, the patient is always like, well, actually, some of them say, yeah, but most of them say no, and then the person in the room will kind of give me this look like, oh, maybe. Well, I think it's just when people kind of think about the same problem over and over again, it frustrates their significant other or whoever they're with, that, you know, they have to hear about this stuff all the time. So I'm loosening up the scar tissue in this region. Definitely freed it up. I mean, if he has pain, that pain usually implies either scar tissue that's adherent or some gland that's a reaction, but I can definitely feel some scar tissue right in here. You know, it's not that easy to get into the muscle and to damage the muscle. I think a lot of people sometimes are like, oh, they think their muscle's been damaged. It's pretty hard to kind of get in. I mean, I guess you could, but the fascia on top of the muscle is pretty significant, and as long as you're not like diving in there, it's unlikely that you have muscle damage. And, you know, even if you did, let's say, get a shark bite of an area of the pec muscle, it just doesn't have much consequences. Maybe in a contour fashion, but not really functional. You know, in my earlier days as a microvascular plastic surgeon, we would take these muscles and move them all over the place, and they're big swaths of muscle tissue and pretty hardy.
Heather, can you turn the light on, please?
We're doing some lipo.
Just getting out that fluid.
You know, Heather, can you get me my headgear with the light? I think that'll help.
It sure is.
So as you all can imagine, I do a lot of gynecomastia, and there are days like today when no one's a primary case. It's everybody's had it done, you know. So primary case means it's never been, you know, it's your first case. Secondary means it's already been done once. Tertiary twice. Quaternary, it's been done 3 times. What's the most we ever did? Like
I think quaternary, right?
Huh?
Quaternary?
4 times, yeah.
Yeah.
4 times the charm.
4 times the charm.
As you know, there's not a lot of body fat here.
And this is also lateral. Usually the lateral area here is not full of gynecomastia tissue. It radiates centrally here, but you know, this is pretty lateral. I wonder if it's just scar. And when was his last surgery?
We'll get it for you.
This is all scar.
2011.
2011. All right, so this is a better view now.
It's a while back, yeah.
I'm looking down the pike.
I'm watching.
Right in the middle there. Yeah, and put the longer.
I was wondering how you were going to get over that far.
Table up a bit, sir. I'm glad I put these glasses on because, man, it's any previous surgery by definition is going to have scar. And that's also why everybody is instructed to massage when you're done, because you're managing the scar as it's developing during the healing phase. Yeah. Alright, so I got the whole area exposed. Undermined, I should say. You come over here, Mike, you may be able to see more down the line here.
Yeah.
I've got stools over there too, Micah.
I mean, I don't know if you... Can you see in there?
Yeah.
Or is it better if the light's on?
With the lights on, good.
Yeah, you see that? So, looking at that, his pec is under here, but this is this fluffy tissue here, but it looks like scar, so I'm gonna work. Okay. I'm gonna work just to sort of hold this gentle. See if I can separate scar. Let's take it out for a second. All right. We can get underneath this scar. You can come back here, Mike. You'll be able to see much better. So what I'm doing,
Again, you can pull my stools up if you need to. They're right behind. You can get closer too. Is it easier? I mean, you can move that whole thing. To get the angle you want. There you go.
so I'm working all this white is scar, and beneath me is muscle. But all this, see all this white stuff? You gotta be careful what you take and what you leave. You know, I could use the bogey.
Heather, can I have it?
Okay, this is just a little different than your normal procedure, yeah?
Yeah, this is finessey. So I got my loops on here, and Heather is getting the electrocautery unit out.
Thank you.
Because I'll
Do you want a Colorado tip?
regular tip I think
Okay.
will be
I
fine.
have the blue tip. That's in there.
It'll give me a better dissection plane. We up and running?
Not quite yet.
But you can see
Thank you.
this is real.
I have it at 45. You want it?
Oh yeah, way too high. Give me down like 25. Alright, this is the electrosurgery unit.
Heather, can I also have Raytex? Oh. Raytex, I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And I also have 2 hypos as well. Because you added 2 hypos.
Bobby tips too.
2 Bobby tips.
So you feel like this is all scar tissue from
Oh, for sure.
previous procedures?
Well, I think that's real.
Show you that. Did you see that?
Yeah.
Okay.
Hold it. And all this is just not normal. I mean, scar tissue and or some of his. glandular tissue. You see how the muscle is, I'm getting right in that plane and leaving that muscle down and just taking the scar. And I'm not removing it all, by the way. I gotta leave something to work with so I can suture it up. But to debulk it as much as possible. And what's cool is you can see in this picture here, clearly he's got this area of fullness. Look at that. And that's shaped perfectly to what he had.
Size, yeah.
Yeah. I like to see fat coming around the corner. Boom. Bam. That was your problem.
There's no light right there.
So put that there, and there's the other piece too.
Okay.
Yeah. That's significant.
So call it what you want. That's real. That's what's visible. That's what he was able to feel. And this was what made it painful. Vindication.
Good.
And you can see in there, that looks nice now. We're gonna use a Penrose drain in here. And Penrose, give me a 1/4 inch. This is his muscle below here. He's got a nice layer of tissue above, which is good. This is not gonna move much here. But I can get some movement here. So I'm going to try to put a stitch in here possibly. Let me just see how it works.
3/0 nylon.
So this is the fascial layer. This internal suturing that I taught you about. Hang on, it's pulling too much. There's another end of it.
Thank
I
you.
just want to know if it pulls too much though. Okay. So what I'm going to do is I'm going to tie this up and see how much it pulls. Not bad. And you can see this long scissor. See this little pinch here?
Yeah.
That's where it's adherent. So I'm going to undermine it.
So we can re-heal.
Yeah. Lay down. This scissor is compared to the
Sharp scissors.
sharp one. It's like, well, why do you use the dull scissor? It shouldn't be dull, but it is.
It's right here. It sticks out.
Yeah.
Putting your finger and putting your finger.
Mm-hmm.
There you
Boom.
go. Boom.
There's just a.
You wanna?
I don't know.
Doing scissor stitch. Sorry, Mika.
Mm. So, this is called working in a hole. Welcome to plastic surgery. All right. And we do this to try to avoid adding any additional incisions. Mm-hmm. Okay, force it.
Scissor or stitch?
Stitch. So this is an area I think that was adding just a wee bit of fullness underneath there. So now I'm going to see if I could suture this and see if that doesn't improve the overall shape.
What's that? Next to her computer monitor. It's in the charger on the zip file.
Right there.
Mm-hmm. So as I said before, there's still some scar tissue that's in there. It's a thin layer and it's manageable, and that's why he has to work his chest for months afterwards to keep it smooth and soft. But that's much better, much more symmetrical. You can see all the scar tissue. Up here. I'm just releasing these tether points. And that's so the skin can just lay out nice. Good. And down the pike here, it looks good. A little bit more hemostasis. Tell them what a Penrose drain is, Mar.
Okay, I'm going to show it to you. So, Penrose drain is a drain. This is a Penrose drain. It's like a straw, basically, to think of it like that. He will pretty much only have like this much in. And then pretty much what that's going to do is take any fluid out that it's going to go all the way this way, and it's just going to take any fluid out that is accumulated over the next like 24, 48 hours. And then it doesn't stay in long, and something that you can go home with, we can teach you on how to take it out, or you can come back the next day, we can take it out for you. Something very easy, simple. It's not like an indwelling drain. You'll see this will actually stick out. You'll see that part when you're coming out of surgery, and it pretty much comes out. And then once we take it out, the little area where it's been in will close up on its own. You don't need any closure or anything like that. And then that's about it.
Just like a little emergency exit for any.
Yeah.
bleeding
Now
in
it comes
there.
out the incision,
It doesn't build up.
so the incision will be a little bit more delayed healing in that area, but it'll heal up just fine. So it doesn't
Yeah.
make scars or anything like that.
Just to get any extra fluid out.
Why do you want to get the fluid out?
You don't want to develop scars, especially with this case.
Right. So
Extra fluid creates more scars.
hold this.
Yes.
Well, fluid of any type, whether it's scar tissue or,
whether it's blood,
blood
whether
or just seroma fluid, yeah, that's going to make the scar tissue.
especially with his case, it being this is the third time he's had surgery, he is even more likely.
Okay, that looks
to
good.
scar.
That looks real good. Happy. Can you cool it off in here, please? Okay, let's stuff that in the meantime, Mar.
Okay.
Put your Penrose in.
Okay.
Rotate her back, him back.
Level or away?
Level's good. And now what I'm going to do here is look on the other side where, what did he say? He said, his doc said,
He was having some pain over there, I remember, but he did say that the previous surgeon left some gland.
On that side.
I think on both, but
you turn this down a little bit, please. All right, so I could see some whitish tissue, but you'd kind of expected to see it. Yeah, he's gonna have some scarring at surgery here. This is muscle under here. And just for completeness, we're definitely going to take pictures of his tissue that we get out on both sides on his chest so he can see it. It actually feels good for him to know that he wasn't seeing things. And like I told you, most people, if they're pretty legit, it's there, and they know it. All right. So it's scar tissue above. See some nice yellow, which is beautiful fat. It doesn't have a lot of fat.
Why do you like seeing a little fat?
Well, it's normal tissue. Just connotes normal as opposed to white scar or gland, gyno tissue. So we're just trying to have a beginning and an end point to dissection. It's obviously not much because that's why I'm being careful here, and that's why I got these high-powered glasses on. But it's precise, and it's real. So I'm not trying to make a mountain out of a molehill, but it's certainly not a molehill. He doesn't think it's a molehill, and it has to be done right. Voila. So that's real too.
Right here.
And that was right there, and that's what we felt, and that's what he felt. Now after I remove it, I'm going to sort of patch up the defect, putting in my sutures into fascia, cover the muscle in the middle. Boom. You can see the fascia right there, that little white layer, and then on top of that is some fat. And the fat is between the overlying skin and the underlying tissue. So we want a nice gliding plane so nothing gets stuck. Nothing bleeding. How many, Davey? One here. I got it. Let go.
Sorry, Micah.
Oh no, I'm your way.
I'm going to tell you from history, these smaller cases are the ones that bleed. Don't ask me why. Mm-hmm. Right here. Mm-hmm. Turn this up a bit, the cautery.
Here, let me clean you too.
Good? Persistent little booger, that's what we call this. Okay, one more stitch
It's in your hand?
in my hand. This fascia, that fascia. Done. All right, so what I'll show you here is that that mass has been removed. It was real, and that's just dermis. There's nothing left. That's normal. And look at the fat here, which is beautiful as well. It's nice and flat, good symmetry. Good symmetry. Good.
The only thing I see right here, Dr. C,
Mhm.
it looks like it's a little tethered right there.
Yeah.
A
A little bit. Take a look.
I just noticed that.
Yeah.
It's right. It's almost like right where his tattoo. And
Undermining. Looks good. So let me get one more down there, and then I'm going to put the Penrose drain in, and we'll show you. We'll pick this up with after we close them up, and the Penrose drain is in. Oh yeah.
All right, guys, we are 1 day post-op from this tertiary case, meaning third time around. And so this patient has not gotten to take a look at his chest yet, so this will be the first time for him to see it.
Great unveiling.
The great unveiling, yes. All right. This off. This is the lipophone we used. All right. Got quite a bit of blood over there. That's pretty normal. Let's see here. Trying to be gentle with you. You okay?
Yeah, so far so good.
So we did use a drain in here.
Okay.
So that is ideal. We got lots of stuff out. It worked the way we wanted it to. There we go. Not so much over here, but we did use a little drain right there. A lot of times with these cases that are secondary or say the third time around, you're dealing with scars, so they can be bloodier. And so we use drains very rarely, but I would say in these cases where they've had previous operations, maybe like 25% of the time we use them, just depending on the case. He's very muscular, and so a lot of times if you have the scar just attached to that rock solid muscle, it can be kind of a bloodier situation. So, okay, I'm gonna have you lay your head back for me there just so I can see here. Good. All right, so we're gonna take out this drain. We're gonna get Dr. Caridi in here to take a look. But as you can see, you've got some swelling right here, so it is kind of hard to appreciate. But you'll be able to see the border of his pec better, and that scar tissue that was sitting there is gone. And so he'll have much more symmetry, which was what we were hoping for, right?
Cool.
And over here, he did not have much. Dr. Caridi opened it because he said there was pain there. And so we always want to investigate. And he was able to take about a quarter size piece of scar out of there. And so we've taken good care of him, and then we'll take these drains out and we'll send him on his way